طيب السلام عليكم. أنا غصي عبد السلام من كسلة، سعودية جنوبية. إذا زول زار كسلة. خرجت من الخرطوم 95 أكتوبر 95. I'm right now pediatric infectious disease attending at Erlanger Children's Hospital in Chattanooga. Chattanooga دي مدينة في South East Tennessee مع الحدود مع جورجيا. فأقرب مدينتين اللي كبار أتلانتا and Nashville. Knoxville is not far away as well. It's a nice place to be in. The main university here is University of Tennessee, Chattanooga. The prominent Sudanese community here is really Sudanese engineers, mainly from University of Khartoum. The current and as well as the previous dean of the engineering School of Engineering is both were Sudanese. Okay, let's me start. That was enough, I guess. Okay, so I will be speaking about neonatal HSV infection. We'll be starting with some clinical cases, some general historic background about HSV infection, some virology, some epidemiological background, immunity to HSV infection, pathogenesis in general for HSV infection, and then what's unique about neonatal HSV infection, diagnosing neonatal HSV infection, managing these patients, and preventions. So I had like 60 something slides, so I might be rushing through this one. Okay, let me admit you as I go on. Okay, so an important concept for us in pediatrics because we deal with newborns is days of life. So you see DOL a lot in my presentation with the clinical cases. So I'm starting with case one. This was a 34-day-old male infant born at 29 weeks and 4 days by gestation. Was born by spontaneous vaginal delivery to a lady who's 25 years old. Birth weight was 1.3 kilograms. On day of life 33, the patient was noted to have multiple bradycardias and apneas episode, which are very common in NICU babies and non-specific. However, that result into increasing respiratory support from his baseline of 2 liters per minute to 4 liters. At that time, they did some workup, including electrolytes, CBC, CRP, and chest X-ray were all reassuring. Later in that day, the patient respiratory support worsened, so it has to be escalated to 8 liters per minute. And also the patient noted to have hypothermia, which triggered partial sepsis workup, including blood culture and urine culture. The patient was started on combination of zosine and vancomycin. Later on, 26 hours later, the patient has a CSF done to complete the full sepsis workup, which essentially showed HSV infection by PCR. It also showed 34 white cell count in the CSF, dominating by lymphocytes, and also showed some increased protein and slightly decreased glucose. And the patient was started on ASAP repair. Multiple exams of the patient did not show any HSV infection, HSV skin or mucous membrane lesions. Patient CMB was reassuring. There was no increased ALT. Patient had HSV blood send also as well. His blood culture eventually result as negative. His urine culture grew Enterococcus faecalis. So that was case one. HSV encephalitis revealed by the immunodeficiency encephalitis panel 26 hours after presenting with brady and apneas. Case two, this is an X full term, male presented on day of life number 5 with lethargy, decreased breastfeeding, and left eye swelling, which was associated with redness and discharge. He started 12 hours earlier, delivered at home, which is not uncommon in this country. Mother reported uncomplicated pregnancy and had no any sexually transmitted disease, and she was GPS negative as well. When seeing the ED, initially the child was, the baby was febrile to 38 Celsius rectally, otherwise has unremarkable vital signs. A full sepsis workup was done, including blood culture, urine culture, and CSF studies. as well as as well as swab from the eye for chlamydia and gonorrhea nuclear amplification testing. His CBC, CMB, and CRB were always normal. Patient was started on Sebabim and Bacillin. 36 hours later, corresponding with the of life 7, patient continued to be febrile with a negative swab from the eye, negative blood culture, negative urine, and CSF culture. And he had persistent eye swelling. And at that time only, a vesicular lesion was noted. So at that time, here is a picture of the patient. You can see the subtle vesicular lesion down there as well as up here. So at this time, a swab was taken for HSV1 and 2 RNA by PCR, which is done in-house for our hospital, and resulted quickly being showing HSV2. And at that time, I was consulted. The father said that he had recurrent cold ulcers. We obtained LFTs which were unremarkable, and we asked for repetition of the CSF to continue ASAP repair, which was started already, but also get ophthalmology on board. Here is the CSF of the patient compared to when he came in to day 8 when the LB was done. So the LB essentially showed the HSV2 being there. The ophthalmological examination was unremarkable. The patient was, they suggest adding terifluridine drops for 4 weeks for that infection, but there were no corneal or dendritic lesions. Case 3 is more complicated. This was a newborn straight away who was born at 35 weeks plus 5 days by gestation. The mother was 22 years old. She had premature rupture of membranes, not prolonged rupture of membrane, only 2 hours before the baby came out. The mother infectious workup has been negative, including GPS, RBR, HIV, hepatitis B, hepatitis C, and gonorrhea, chlamydia, nuclear amplification. The baby was noted to have his circumference less than 1 microcephalic. Otherwise, his weight was on the 50th centile and his length was on the 60th centile. However, more importantly, he has very extensive skin erosion involving the neck, right shoulder, and arm, but also a hypopigmented area in the lower back. There were no vesicular lesions. Here's a picture of the patients. I hope it's not that gross to you guys, but you can see what I mean by those definitions. Then that's the right shoulder up there, on the back, upper shoulder, and upper back, and the lower back, showing the hypopigmented areas. Please stop me at any time if you have any question or comment. So I was on vacation around that time. So my colleague from Memphis were covering me remotely. So they suggest doing a blood culture to be held for fungal growth, doing RBR on the baby regardless of the maternal RBR workup, as well as herpes evaluation, including surface culture, wound culture for HSV, as well as blood HSV, BCR, and ALT, and LB, as well as varicella evaluation with a BZV, BCR from the wound. And they suggest starting ampicillin, gentamicin, acyclovir, as well as fluconazole, and place the baby on airborne precaution just in case it's varicella, and suggested abdominal ultrasound as well as cranial ultrasound and eye examination. The monitor, you are also on board. They recommend routine wound care. So the wound care team was involved. Vaseline to the denuded area and no stick dressing. Here's a lab workup for this patient at short after being born. He had anemia, which is atypical for newborn. Hemoglobin was 13. His Wasser count was on the lower side. He had increased bands, but normal platelets. His CMB was unremarkable, but that probably reflects the maternal function rather than the baby's function, so it's not advised to do CMB immediately after birth. His blood culture proved to be negative. His wound culture for bacteria as well as fungi were negative. His RBRs non-reactive. His varicella zoster from the lesion were negative. HSV blood PCR was negative. the HSV viral culture, which are generally less sensitive to compared to PCR, were negative. These forms were from the eye, from the mouth, from the skin, from the rectum. That's the routine when you are confronted with HSV infection. The CSF was remarkable for a bloody tap with increased protein, but the meningitis encephalitis panel was negative. And then on day 3 of life, the baby had, when they realized that the culture will take time because that is sent out from our hospital, whereas the HSV PCR is done in-house. They send that sample on day 3 of life, like pretty after 3 days of acyclovir, and that proved to be negative. So back from my vacation, I have no microbiological diagnosis. The skin lesion improved. The wounds were negative for the HSV infection. So I suggested continuing combination of the ampicillin and gentamicin to complete 10 days and the fluconazole for 14 days with no microbiological backgrounds. It just came with this arbitrary number, honestly. And then because of side effect, I suggest discontinuing acyclovir, given no evidence for varicella or HSV. And I suggested that if the patient becomes septic because of his skin involvement, I would treat him as a possibly parent patient. And I also suggested to do HIV PCR testing on the baby because the mother reported to have 2 STDs during her pregnancy. And on the same day I saw the baby, the skin biopsy was done, so I plan to follow that up. The skin biopsy came with basically confirmation of the denuity ulceration, and they suggest to consider aplasia cutis with ulceration. A special stain for microorganisms were negative. Those include HSV infection as well. The histopathology shows some multinucleated histocytic Guyan cells. So overall, the changes in this biopsy are not specific, are most compatible with changes due to ulceration, chronic inflammation related to ulcerated denuded skin. Considering high clinical suspicion for aplasia cutis, these changes, although not characteristic, could be compatible with aplasia cutis with secondary ulceration and inflammation. That's the pathology report. So we stopped the acyclovir, and then 7 days after that, the patient developed new lesions in the right lower abdomen and bilateral inguinal area, consisting mainly of pulli, otherwise well, hemodynamic stable. So these are the lesions. You can see the plus formation on the right lower abdomen, that's umbilicus, as well as the inguinal area. So I was following up the baby closely, came back and the next morning and examined the patients. And this was my assessment. I said most compatible with Pelosi impetigo. However, given no microbiological diagnosis for his initial lesion, we suggest that and patient might have an underlying skin condition that predisposes him to infection, to treat for HSV infection as well as Staph aureus infection. His MRSA nasal swab was done on day 9, was negative, so I suggested adding cefazolin acyclovir, pending those lab results, which include HSV 1 and 2 RNA from the after opening the lesion. And if the HSV PCR were positive, to repeat another LB. So LB was the HSV actually was HSV2 was revealed by the PCR testing from the lesion this time. The LB done on 2 days down the line was negative, luckily, although she showed a bit of increased white cell count dominated by lymphocytes. So, and then we did ask for skin biopsy, which is done the next day after the lesion evolved. And this also reveals a multinucleation with intraepidermal vesicles and appropriately controlled HSV 1 and 2 immunohistochemical staining were positive for HSV2. So those were the cases. I will give you an update later on after going through the rest of the presentation. Here is a historical background about HSV infection in general. The word herpes, from Greek is to creep, has been used in medicine since antiquity. cold sores, herpes fibrilis, were described by the Roman physician Perdollus in AD 100. Genital herpes was first described by John Astor, a physician to the King of France in 1736. The first translation of this of his treatise or venereal disease appeared in 1754. I didn't know that the French preceded the English or the British in terms of some medical advancement. Transmission of infection in oral label lesion was documented in late 19th century. An experimental transfer of the disease to rabbits was accomplished in the early 20th century, and HSV was grown in vitro in 1925. And lastly, in the 1960s, Nehemias and Dolian reported two antigenic types of HSV with different stages of viral recovery. Any comment from the virology colleagues in this background?
That is excellent, I'll say. Yeah, people knew about it, but they didn't know what it was. Even the great Ghussai had described the histopathologic findings of it just before 1925, I think 1918, 1920. And then this experiment that you told about, you can transfer it to rabbits, but people did not obviously know about they knew it was a virus because they couldn't see anything. It's just the cytopathology. And until 1930 something, when the electron microscope was invented, then people could see the herpes virus at that time. And then later on, of course, they knew about HSV1 and 2. But yeah, it's fascinating.
Interesting. Yeah, thank you. So uh, background of the HSV virology. So herpes simplex virus type 1 and 2 belong to the herpes viridae subfamily of herpes viruses. These are also known as human herpes virus 1 and 2. HSV is an envelope virus which has a 160 nanometer in diameter, as it has a linear double-stranded DNA genome. Complete DNA sequencing demonstrated greater than 90% homology between HSV 1 and 2, although one of the references suggested 50%. So again, you three or one of the other colleagues can comment on homology. I'm not a virologist. Do you have any input from your side, you three?
Yeah, I mean the homology is around 90% or even more in the conserved areas of the genome, and the size of it that is the 160 nanometer, but I think the size of it still in terms of genome size is smaller than varicella zoster virus and then smaller than CMV. CMV is the biggest one of them in terms of the genome and the open reading frames within the genome.
Interesting, thank you. So it does, the HSV genome encode at least 84 different polypeptides. These include glycoprotein embedded in the viral envelope, capsid protein, DNA polymerases, protein kinase, and other bioenzymes. DNA binding protein involved in viral replication, and many other proteins with poorly understood biological function. So HSV infection occurs through attachment to cells via efficacious receptors, and the viral replication occurs through nuclear and cytoplasmic phases, including attachment, fusion, DNA replication, capsid formation, and aggression to infect other cells. Latency occurs within neural ganglia and is associated with transcription of only a limited number of virus-encoded RNA at baseline. Here is a cartoon of the virus, and the glycoprotein is the main mediator of immune response. In terms of epidemiology, HSV infection can be transmitted from people who are asymptomatic or symptomatic with primary or recurrent infection. The prevalence of genital HSV infection during pregnancy, as well as the incidence of neonatal HSV infections, influenced by socioeconomic status, age of the patient, and sexual activity and practices. The incidence of neonatal HSV infections in the USA has increased apparently over the last 2 decades to around 1 in 2,000 live births. It depends where you live or your practice. 50% of cases are due to type 1 now, but it could be as low as 20% in other places, and 50% or 80 up to 80% are due to type 2. Overall, type 2 is more common, which makes sense. Infection acquired in utero, i.e. congenital rare, representing less than 5%. Most infections result from exposure at delivery to mother shedding virus in the absence of symptoms. Maternal primary infection is associated with a much higher neonatal attack rate than maternal recurrent infection, 50 to 60% versus 2% only. Is less common source of neonatal infection. May I include also postnatal transmission from a parent, from a sibling, from other caregiver, including health workers, unfortunately, mostly from non-genital lesions like mouth or hand lesions. And transmission from the mouth of a religious circumcision, what they call mohel, to the infant penis during ritual Jewish circumcisions that include dark or genital section, what they call mistazia epa, if I pronounce it correctly. uh, so most of the literature in this country for HSV infection come from Dr. Brown, I believe in Seattle, University of Washington. So starting with this paper from here, from them in 1997, the acquisition of herpes simplex virus during pregnancy. So they studied 7,000 pregnant women on whom they obtained serological testing uh, uh, um, to show if these are at risk of HSV infection or not. So the serum sample were obtained during the first perinatal visit at approximately 16 and 24 weeks of gestation, as well as during labor. These were tested in the old days by Western blot for HSV1 and 2, and the results were correlated with the occurrence of antenatal genital infection. 94 women became seropositive during their pregnancy. 34 had symptoms consistent with herpes simplex infection, and 60 of these patients, or 64% of those women, were asymptomatic, or the physician or provided not to recognize the symptoms. So HSV conversion complete by time of labor was not associated with an increase in neonatal morbidity or with any cases of congenital infection. However, among the infants born to 9 women who acquired genital infection shortly before delivery, neonatal herpes simplex infection occurred in 4 of infants. One of them died. So they conclude that 2% or more susceptible women acquire HSV infection during pregnancy. Acquisition of infection with seroconversion completed before labor does not appear to affect the outcome of pregnancy. But infection acquired near the time of labor, like third trimester, is associated with neonatal herpes and perinatal morbidity. We'll come to more of that later. This was a study from to see the risk factor of like looking for the risk factor for herpes simplex virus transmission to pregnant women. A couple of studies. They basically looked into couples, women in prospective study of HSV acquisition in pregnancy, invited their sexual partner for HSV type specific serological testing. Risk factor for herpes simplex infection susceptibility, exposure, and acquisition were examined. They recruited 3,000 couples. 22% included women at risk of HSV 1 or 2. Among 582 HSV seronegative women with HSV seropositive partner, 14 or 3.5% acquired HSV infection. Having a partner with a history of oral herpes was associated with HSV acquisition. The odd ratio was 8.1, and the confidence interval was for 95%. Confidence interval was 1.8 to 3.6, a big range, and accounted for 75% of incident infection. Among the 125 HSV2 seronegative women with HSV 2 seropositive partners, 17 or 20%, just for gestation lengths, acquired HSV infection. During the duration of the partnership of 1 year or less, so with HSV acquisition, and account for 63% of incident infection. No combination clinical characteristic could be identifies the majority of susceptible women with serological discordant partner. And they conclude that HSV acquisition rate in pregnancy are high in discordant couples. especially for HSV2 clearly. Interventions that address risk factor for HSV acquisition should be studied in pregnancy. Clinical profile cannot replace serological screening to identify susceptible women with serological discordant partner. Any comment from any of the colleagues on these two studies so far? If no, in the rest of time, I just go ahead with the next study. This was primary maternal herpes simplex virus 1 gang of stomatitis during pregnancy and neonatal herpes case series and literature review. This was published in July 2012. Um, Basically, they reviewed medical record for neonates less than 4 weeks of age with confirmed diagnosis of neonatal HSV at a single pediatric center over 19 years period to identify cases in which the mother had primary gingivostomatitis during the pregnancy. They had 7 neonates whose mother had primary HSV gingivostomatitis during pregnancy. From out of 48 neonates with laboratory to confirm HSV neonatal disease. Of the 7 women, 2 presented with symptoms of primary HSV gingivostomatitis during the first trimester and 5 in the third trimester. 3 of the neonates developed skin, eye, and mucous membrane disease. 2 developed central nervous system, and 2 developed disseminated disease. One of these neonates with disseminated disease died eventually. And they conclude that primary maternal HSV gingivostomatitis during pregnancy may lead to HSV1 transmission to the baby, such that physician caring for these women should communicate the diagnosis of HSV gingivostomatitis to the neonate's primary provider to ensure proper communication and early evaluation as needed and prompt treatment.
Also, can I just interject?
Yeah.
That line that you had in red there.
Yeah.
I had a case in I think 2009 where there was a gingivostomatitis in the mother while she was in the labor room, and she was treated as a candidiasis with some remedy to her mouth, but the baby presented on day 10, and he was just like these 2 patients that were mentioned there, 2 babies mentioned there, developed disseminated disease. And only in retrospect that we kind of guessed that the stomatitis that she had while she was in the labor room was HSV1, and unfortunately the baby died of that.
Okay. Yeah, obviously an excited mother will be kissing her baby, so here you go. So again, back to Dr. Brown group study. This was published in January 2003. They did prospective cohort. Actually, they meant to determine the effect of viral shedding, maternal HSV serological status, and delivery route on the risk of transmission of HSV from mother to the infant. So they did a prospective cohort of pregnant women enrolled between 1982 and December 1999. They recruited 58,000 pregnant women, of whom 40,000 had HSV culture obtained from the cervix and external genitalia, and 31,000 had serum sample tested for HSV. They were looking for rate of neonatal HSV infection among 202 women from whom HSV was isolated at the time of labor. 10 or 5% had neonates with HSV infection. And they suggest that cesarean section delivery significantly reduce HSV, or they found cesarean section delivery significantly reduce HSV transmission rate among women from whom the HSV was isolated, with a p-value of 0.047. They also look for other risk factors for neonatal HSV, including first episode versus HSV isolated from the cervix versus HSV and compare HSV1 and versus HSV2 isolation at the time of labor, delivery before 38 weeks, and maternal age less than 21 years old. This seems to be the high risk factor for these babies. Neonatal HSV infection rate in their study was 100,000 live versus 54 of those were due to HSV in HSV negative women, and 26 were HSV positive women's for HSV1, and 22 actually were among ladies who were HSV2 seropositive. And they conclude that neonatal HSV infection rates can be reduced by preventing maternal acquisition of genital HSV1 and 2 infection near term. But the method has to be investigated, I guess. It can also be reduced by cesarean section delivery and limiting the use of invasive monitoring among women, because we know that electrode, like a scalp electrode in the baby, can cause skin erosion, and then eventually the HSV can invade the baby. I will come to this later on as well. Um, so what does the American College of Obstetricians stand in terms of investigating these ladies? So they suggest that retesting is not needed for prior confirmed history. If the mother had history of HSV infection, you need to confirm. Use of type-specific HSV testing when with active lesion, obtain a specimen for culture, antigen or molecular testing. This was from 2020. History of, if there is a history of ulcer, no active lesion, obtain type-specific serology. But they suggest there is no sufficient data to recommend routine screening of all pregnant women for HSV. And obviously they recommend oral acyclovir suppression around 36 week of gestation if the mother has genital HSV infection. Now coming to pathogens. Before that, if anybody has any comment on the epidemiology, can add please. If not, I will go ahead with the pathogenesis in the interest of time. So HSV1 and 2 exhibit particular tropism for cell of the ectodermal organ, including the skin and the neuron cells. Initial viral replication is thought to occur at the portal of entry, usually in the mucous membrane or skin. Then the virus replicates in the epithelial cell, producing the characteristic vesicles on a rhizomatous base. It then ascends the sensory nerves to the dorsal root ganglia, where after the initial period of replication establish latency. During reactivation of infections, the virus spread distally again from the ganglion to initiate new cutaneous or mucous membrane vesicular lesions. After infection of the oral mucosa, usually by HSV1, the virus became latent in the trigeminal ganglia. And after genital infection, it became latent in the sacral ganglia. In terms of immunity, primary HSV infection elicit humoral and cellular immunity based on animal models and some human studies. But we know that the initial host response is mediated by innate non-specific mechanism, followed by acquisition of virus-specific adaptive immunity. The innate response followed by production of antiviral antibodies that can be detected 2 to 12 weeks after infection, so a bit of gap. HSV-specific antibodies mediate neutralization of the virus, complement fixation, and cellular or complement cytotoxicity. Induction of specific cellular immunity is detected by measuring T cell recognition of HSV protein in proliferation and cytotoxicity assays and production of interleukin 2 and interferon gamma. Failure of virus-specific cell-mediated immunity to develop can be associated with life-threatening disseminated HSV1 or 2. And however, despite extensive investigation, specific immunological factors that modulate clinical course and outcome of HSV infection remain completely not understood. Fatal severe HSV1 infection occur in individuals with innate immunity defect in natural killer cells as well as plasmacytoid dendritic cells. The cellular immune response is critical for control of infection. Substantially diminished HSV antigens stimulated lymphocyte proliferation and reduced interferon production are observed in infected neonates and also in postpartum women, compared with response in non-pregnant adults or non-parting adults overall. The important role of antibody in HSV infection is evident from investigation of neonates exposed to HSV at the time of delivery, as we have seen from those studies discussed earlier, such that those exposed to HSV2 in the presence of transplacentally acquired neutralizing antibody are significantly less likely to contract the infection And if infected, usually it will be a localized infection rather than disseminated or involving the CNS. It's also notable that title of the antibodies that mediate the antibody-dependent cellular cytotoxicity correlate inversely with severity of the neonatal infection. And then they noted also the certain deficiency in signal transducer and activator transcription when UNC93P toll-like receptor and TNF receptor associated factor 3 and mutation of the nuclear factor KB, which is an essential modulator in patients with recurrent herpes or severe herpes encephalitis in general, not in neonates. In general, that this could be associated with very severe herpes encephalitis as well as recurrence. Any comments on the immunity from our virologist, please?
Yeah, I mean, this is although they are immunological assays, but the clinical evidence that you presented earlier was very consistent with it, wasn't it? So the discordant couples, the people who were antibody negative, the problem tend to occur more in their babies. So it was and of course the place of cell-mediated immunity in controlling the infection and maintaining latency, as opposed to this humoral arm of the immunity, is very well known in all viruses, but in particular in herpes viruses. So there's nothing really surprising here. And I don't know, the premature, the first case you presented was the premature baby, but the last one was term, I think, but was already damaged by the virus, maybe from very early on during in utero stages. But yeah, the last paragraph here, the specific deficiencies that were known to occur although herpes encephalitis in general is a rare disease, but in the cases where people have succumbed or have permanent damage, many of these genetic defects have been demonstrated. So if somebody is unlucky, or a child is unlucky, then the mother will be seronegative, got no cell-mediated immunity, and then get exposed to the virus. That child, if you've got an immune problem, any one of these defects, then the outcome is likely to be catastrophic.
Right. Yeah. Thank you for that. A few words about HSV serological testing. So in this country, clinical laboratory use ELISA or immunoblot method to detect HSV1 and 2 type-specific IgG antibodies. These assays use specific HSV-GG antigen and can be used to show whether an individual is infected with HSV1 or HSV2 or both. Before 2000, the year 2000, commercially available serological testing were unable to distinguish between the antibodies to HSV1 versus HSV2. So thus they were limiting in their they were very limited in their utility. The sensitivity of commercial IgG type specific HSV serology tests range from 90 to 98%, with specificity greater than 94% when compared with Western blot. So Western blot was used in the old days. As with any serological test, obviously there's a chance for false negative results, especially with early infection, and false positive results may occur in patients with low pre-test probability exposures, as we know. In general, IgM testing for HSV1 or HSV2 is not useful because of the lack of reliable commercially available IgM assay overall. Serological testing is not useful in neonates.
Do you send this away, Ghussai? Do you send
Yes.
the samples away?
Go ahead.
Do you send the samples to a central lab or a reference lab for
It's commercial lab now in a hospital, unfortunately. So I send out, but it's a commercial lab again. The USA like big businesses.
Okay.
Yeah. Okay. So maternal HSV historical status and transmission risk, we discussed that earlier. This is the risk of transmission to a neonate born to a mother who acquired primary genital HSV infection near the time of delivery is estimated to be 25 to 60%. In contrast, the risk to a neonate born to a mother shedding HSV as a result of reactivation infection acquired during the first half of pregnancy or early is less than 2%. However, overall, more than 3/4 of infants who contract HSV infection are born to women with no history or clinical findings suggest of genital HSV infection during or preceding pregnancy. Therefore, a lack of history of maternal genital HSV infection does not preclude the diagnosis of neonatal HSV disease. Let me go back. So here are the main 5 factors known to influence transmission of HSV infection from the mother to the neonate. 1, the type of maternal infection, primary versus recurrent. 2, maternal HSV antibody status. 3, duration of the rupture of membranes. The longer the duration of membranes, the higher the risk for HSV to go through the membrane to infect the baby. Integrity of the mucocutaneous barrier, such, for example, using the fetal scalp electrodes to monitor the baby before it's being born, and the mode of delivery, cesarean versus vaginal delivery. I will be considering from now into the spectrum of generally the spectrum of neonatal HSV clinical presentation. Generally, the initial sign of HSV infection can occur anytime between birth and approximately 6 weeks of age. Although the incubation period for HSV is totally different, but most infected infants actually develop symptoms the first 4 weeks of life. HSV infection occurs when viral replication has been established, but the virus is not causing illness. And then HSV disease occurs when viral replication produces clinical signs of illness, such as skin lesions, encephalitis, or hepatitis. However, overall, once an infant is infected with HSV, progression to neonatal HSV disease is virtually certain. That's why it's very serious infection or issue in neonates. HSV should be considered overall as a causative agent in any neonates presenting with fever, especially in the first 3 weeks of life, any neonates with a vesicular rash, conjunctivitis, or abnormal CSF analysis if the baby comes fever and they did CSF studies. If the meningitis encephalitis panel is not available for you and the CSF is abnormal, pending the CSF culture, you better add a saccharomyces before you rule out the bacterial meningitis. This is especially if the patient had seizure or during a time of the year when the enteroviruses are less common in the community. Recurrent skin lesions are common in surviving infants. I will come to this later on in our patients, occurring in approximately 50% of survivors, often usually within 1 to 2 weeks after completing the initial parenteral asaccharomyces. So one of the ways it can present is a disease localized to the skin, eye, and or mouth, what we call SEM disease. This typically present between the first and second week of life and contribute to approximately 45% of neonatal HSV infection. However, more than 80% of these neonates will have skin lesions, and those without vesicle initially have this infection or lesion may be limited to the eyes or the oral mucosa. Here are a picture of this patient. The first on the left here is a probably disseminated infection. Conjunctivitis, less sort of skin infection, and infection at the scalp, electrode used for monitoring during the before the baby was delivered. Disseminated disease is typically present between the first and second week of life. 25% of neonatal herpes simplex present that way. Disseminated infection should be considered in any neonate with sepsis, but with blood culture being negative and as well as a bacterial culture being negative. Any child with severe liver dysfunction, any child with neonate with disseminated coagulopathy or suspected viral pneumonia, especially if the patient had hemorrhagic pneumonia. approximately two-thirds of these neonates with disseminated disease or CNS disease have a skin lesion. However, initially the lesion might not be apparent there. That will delay the diagnosis. And then last, the most serious one is localized CNS disease with or without skin and eye or mouth involvement. These around 30% of neonatal HSP are presented that way. And usually is a late presentation, usually in the second and third week of life. And in the absence of skin lesions, the diagnosis could be very, very challenging, especially if the LB was not done earlier, or if you don't have the HSV PCR, RNA PCR available for your CSF studies. Before I go there, any comment on those presentation or question, please?
Thank you, Ghussai, for the nice presentation. Ghussai, just a question, adult infectious disease, and really, I have to admit that I don't know the more details that you know it about HSV infection in children. What prevention you can make? Like, I know that sometimes they screen. Is there any standard of practice? Because I have not seen it here. Like sometimes I see in the GYN floor, they screen the strep, but I have not seen any screening for HSV.
It's quite variable from a provider to another provider, and I believe by regions there's no agreement on screening these ladies. Maybe it depends on how the patient, I mean, the risk stratification for this patient, really, if they have high risk behavior, sexual behavior, they may screen them, but there's no standard as far as I know. And that also was the case or the status by the American College of Obstetrician and Gynecologists. So there's no guidelines on that. It depends. Okay.
I see. Thank you.
Ghussai, thank you so much. Thank you, Yusri, as well, for very educative session. I like your comment that the excited mother kisses the baby and he gets herpes simplex. So what is any difference in the outcome between people according to the route of getting the infection? I mean, like if you get it from a mother as opposed to a babysitter, for example.
I didn't came across any data suggestive of that. Honestly, you may know this better than I do. If you can comment.
Yeah, I don't think there is a difference, but the difference that is observed is mainly related to the infectious dose and the status of the baby itself. So a term baby whose mom is seropositive will be protected. So in the assumption that the mother is seronegative, so the baby is at risk, but the mother herself did not have an infection, so there's no exposure in the birth canal, and then the unfortunate baby get kissed by someone who had a cold sore or a lesion in the hand, then that child can get HSV, and it can be as bad as the from the mother. It's just maybe it's going to be less because the inoculum is not as high, and then they may just be able to be detected.
Yeah, that's exactly because what I was thinking. Being closer to a mother, probably you have a higher inoculum as compared to accidental getting exposure. So that makes sense. That makes sense. Thank you so much.
Thank you, Yusri. Coming to the pathology.
Following up,
please.
Yeah, following up to the same question, I guess I'm not sure if I missed it, but I guess is there a difference in outcome if the patient get exposed, during birth or after birth, either from the mouth being HSV1 versus like lesions in the birth canal in terms of the prognosis or outcome?
I looked for some data on that, but I couldn't find anything in terms of prognosis or outcome for this baby in a baby infected by HSV1 versus HSV2. But I feel that HSV1 is probably more nasty. That would be discuss later when we update you on one of the patients, the one who had a HSV in their CSF just revealed by the meningitis encephalitis. I believe it was case number 1. Thank you. Okay, in terms of pathology, this is a postmortem for brain of postnatal herpes simplex, and you can see the hemorrhagic necrosis mainly involves the temporal lobe. That's typical happen in adults as well as teenagers. However, in babies, generally, it's a sort of generalized encephalitis picture, really, with severe atrophy and distortion of the cerebral hemisphere, mostly. So it's to be more extensive in newborns. In terms of diagnosis test, PCR assay usually can detect HSV DNA in the CSF from neonates with CNS infection, but also from the skin as well. HSV grows readily in traditional cell culture. However, you need special transport media for that. You will find cytopathogenic effect typical of HSV infection being seen 1 to 3 days after inoculation. Culture confirmation could be done by fluorescent antibody staining, enzyme immunoassays, and monolayer culture with typing. And cultures that remain negative generally by day 5 are likely to remain negative. A viral isolate by culture is required for if antiviral susceptibility studies are to be performed. My understanding really, acyclovir resistance is not common unless you are immunocompromised and you have been on some acyclovir prophylaxis. But my colleague from virology can comment on that. And there is rapid diagnostic test or techniques that could be used on the lesion, including direct fluorescent antibody staining or EIA detection of HSV antigen. These are specific but less sensitive than culture. But the PCR is the most sensitive one and a specific one. Any comments on this one?
Yeah, I fully agree. So PCR, full stop. The culture is done in reference labs for phenotypic resistance testing, but nowadays we have now genotypic resistance testing, so people could decide by certain mutations whether acyclovir is resistant to or not. But I agree with you. Normally, there is a prerequisite that this person has been or a patient have been exposed beforehand to acyclovir for that to have happened, and normally they are immunocompromised.
Thank you. More on diagnostic tests. So for diagnosis of neonatal HSV infection, all of the following specimens should be obtained. Swabs specimen from the conjunctiva, the mouth, nasopharynx, and anus, what we call surface specimen for HSV culture available or PCR. For me, in my hospital, we do a PCR in-house. The culture are sent out and takes almost 5 days to result back. A specimen of the skin vesicle for HSV culture or BCR also is recommended. CSF sample for HSV BCR assay, a whole blood sample for HSV BCR, and a whole blood sample for ALT because of the risk of hepatitis in these patients. HSV BCR assay and cell culture is the preferred method to detect HSV in genital lesions. The sensitivity of the viral culture is low, especially for recurrent lesion, and as it declines with the healing of the genital lesions. Again, more on diagnostic tests. The performance characteristic of the BCR assay on the skin and mucous membrane from neonates has not been studied, according to our red book. Positive culture obtained from any of the surface sites more than 12 to 24 hours after birth indicative of viral replication, and therefore suggestive of an infected infant, and therefore the risk of progression to HSV disease, rather than being merely contamination after intrapartum exposure. Anything before 12 hours or 24 hours might be contamination. Any of the 3 manifestations of the neonatal disease we discussed earlier, a disseminated CNS or skin mucous membrane eye involvement can be associated with HSV viremia. So a positive whole blood BCR on the blood is not always indicative of disseminated HSV infection because that and should not be used to extend the treatment beyond the specified treatment duration, which I will discuss later. Likewise, no data exists to support use of serial blood PCR assay to monitor response to therapy. However, overall, for any infant with diagnosed HSV disease, regardless of the classification under those three main categories, should have ophthalmological examination and neuroimaging to establish a baseline brain anatomy, ideally using a brain MRI. In terms of treatment, unless someone has question or comment on the diagnostic criteria for this patient. No. So treatment. So parenteral acyclovir is the treatment of choice for this patient. The dose is 60 milligram per kg per day in 3 divided doses, i.e. 20 milligram per kg per dose. Administered for 14 days for skin, eye, and mucous membrane disease, and for a minimum of 21 days for CNS or disseminated disease. All infants with CNS involvement should have a repeat lumbar puncture performed near the end of the 21 days before stopping the acyclovir. If the CSF BCR results remain positive near the 21 days period, another week of acyclovir, intravenous acyclovir should be done, and another CSF BCR should be done as well. I will come to that in terms of outcome of this patient later on by some studies. I'll show them later on. Parenteral antiviral therapy should not be stopped until CSF BCR result for HSV DNA is negative. Obviously, for eye involvement, you can use 1% trifluridine or 0.15 ganciclovir in addition to IV acyclovir. And an eye doctor should be involved in the management of these patients because of the long-term risk for corneal scarring. Unfortunately, it's not displayed very well, but basically studies that to detect HSV nucleic acid in the CSF, and there is a correlation such that if when compared to the clinical course of neonates with persistent herpes simplex virus DNA in the cerebrospinal fluid after 21 days of treatment with high dose acyclovir to those who clear the CSF after 21 days, neonates with persistent HSV DNA had more severe clinical course with worse neurodevelopmental outcome. This is the base for repeating the CSF and making sure the HSV DNA is negative before stopping acyclovir. And this study was mainly to see the effect of the use of oral acyclovir suppressive therapy in neurodevelopmental outcome after neonatal herpes. Infants surviving neonatal herpes simplex disease with CNS involvement had improved neurodevelopmental outcome when they received suppressive therapy with oral acyclovir for 6 months. This suppressive therapy is basically consisting of oral acyclovir at 300 milligram per square meter per dose, administered 3 times daily for 6 months after completion of the parenteral therapy. And the dose should be adjusted for a monthly basis based on the weight gain. And then you have to also monitor the absolute neutrophil count while this patient on oral acyclovir every 2 to 4 weeks for the first 2 months or so, and after that monthly. And longer duration or higher dose of antiviral suppression do not further improve neurodevelopmental outcome. Although there is a trend in this country now to extend the treatment overall to 1 year rather than only 6 months. There's no data for valacyclovir because it has not in this age group because it has not been studied for longer than 5 days in younger infants, so should not be used routinely for antiviral suppression in this age group. So time to update you guys on these patients. If you remember, the first patient was diagnosed with HSV1 encephalitis later, like almost after 2 days of presenting initially with bradyapneas and bradycarditis and apneas. So his repeat CSF on day 52 was unremarkable, including the meningitis encephalitis panel. So he ended having 3 weeks of IV acyclovir. His MRI brain grossly unremarkable, allowing for the patient age. a small amount of susceptibility seen along the epidermal lining of the lateral ventricle, likely related to prior interventricular hemorrhage. And he's had retinal prematurity. Patient received suppression of suppressive therapy for 6 months. And then 3 weeks after completing the acyclovir suppressive therapy, patient diagnosed with encephalitis in an outside hospital while visiting family member, I believe in Texas. At that time, when he was seen in that outside hospital, the MRI brain showed diffuse abnormality involving the bilateral occipital lobes, more broad to the left posterior parietal lobe, left temporal lobe, and portion of the left frontal lobe. There is also involvement of the splenium, of the corpus callosum, and forceps, major and possible also posterior limb of the internal capsule, most consistent with meningoencephalitis. In that hospital, they did a baseline immunological workup, including B and T cell profile, immunoglobulins levels, IgG subclasses, complement 50 all were within normal limits. Patient received in that hospital 3 weeks of acyclovir and then was also put on suppressive acyclovir. Patient currently has still on suppressive therapy of acyclovir. I believe he's coming to the end of those 6 months, the second 6 months of suppressive therapy after his second episode, maybe in a month's time. So I'm eager to see him in 3 weeks' time or so. He currently has intractable seizure with his arrhythmias necessitating multiple medications. I did change his because he was like almost 9 months old when he came back to me. I put him on acyclovir prophylaxis just for a better absorption, and he didn't have any flare from his skin during this time. However, he's still awaiting a formal immunological workup to see why he had 2 episodes of HSV1. So I thought, based on that case, just HSV1 may be more refractory or more serious with that outcome, really. And baby obviously the child obviously has a very severe neurodevelopmental consequences. For case 2, the baby who was full-term baby, born at home and came with conjunctivitis. His repeat CSF was unremarkable. He received against 3 weeks of acyclovir. His brain MRI was unremarkable, and he completed 6 months of oral acyclovir suppressive therapy. He did move to another city, I believe to Memphis, so I haven't heard from him anymore. I did sign him out to my colleague in Memphis, so hopefully they are following him up there. Case 3 was the baby with in utero infection with skin involvement, but no CNS involvement in 2 LBs. He completed 14 days of IV acyclovir, and which followed by 6 months of suppressive therapy. His eye exam was unremarkable. He had a brain MRI which showed preventricular gliosis with abnormal thalamic contours, a small and dysplastic appearance of the bilateral cerebral hemispheres with remote microhemorrhages. These findings are non-specific but could represent the sequelae of an in utero infection or ischemic insult. Patient interestingly relapsed within 2 weeks after again completing the 6 months of suppressive therapy. Hence, we resume that after discussion with the mother, and we are planning to complete another 6 months from that point. The baby currently is around 10 months old. He does have motor delays, and he's following neurology, but luckily no seizure so far, no epilepsy. He does have his strabismus and have referred him to a pediatric ophthalmologist. Any comment on these cases?
And this is totally different from what we see in adult next case.
Yeah,
It is just
it's quite amazing. Wallah,
Yeah. No comment, Ghussai, but it's just very frightening to have herpes simplex.
yeah.
Yes.
I mean,
I don't think many people appreciate how serious this herpes simplex is.
Yeah.
That's interesting.
So, Ghussai,
Thank
the
you so
first
much.
patient.
Yeah.
So I think he was the preterm one, isn't he?
He was
24.
yeah, but all like 29 week or so, if I
Is it?
recall.
Is it? Or before that, I thought he was 20
Let
something.
me,
Okay.
yeah.
So yeah, I mean, but he presented a bit late compared to the other two. He compared like three weeks later, or
He presented around 35 days of life.
yeah,
Yes.
35. So he's week 6 almost DOL, or week 5. So normally that means he had the infection and he present mainly CNS.
Correct.
So they almost people thinking, no, this must have happened transaxonally. So he had the lesion in his hand or whatever in skin, and then the virus tracked back very slowly. That's why it took weeks to reach the CNS. And then, of course, it wasn't discovered immediately. He had a treatment and then he had a relapse. Unfortunately, maybe he had so you're doing your immunological workup. I was just interested to know how is his centile now, his growth. He's 9 months old now. Is he gone back to normal like any other baby, or is there any evidence that he's got other problems?
Uh,
That's the one first question. The second one is HSV1 versus HSV2. Traditionally, when it comes to recurrences, we fear HSV2. HSV2 is the one that is proven to be more prone to recurrence than HSV1. And also, traditionally, classically, the HSV1 is below, the umbilicus, while the HSV2 is above it. But in recent times, and with changing sexual practices and oral sex and all kind of things, people have HSV down, HSV1 as genital, and also HSV2, of course, can happen in the upper part of the body, like mouth. But I don't think there is a difference there. HSV1 is just more common in neonates, maybe, than HSV2, because normally the HSV2 will be recurrent, and the mother would have known that she's got the HSV, and the risk, as you said, is far less than a primary infection. HSV1, on the other hand, a lot of times it is primary, so the mother is not immune. She gets infected very late in pregnancy. The baby is not immune, even if it's term, and then they get exposed, and then they get problems. But the recurrence can happen anyway.
Thank you for that. So the child actually, in terms of growth, is doing okay. If he doesn't even have microcephaly, but obviously has really major neurodevelopmental issues with
Yeah,
intractable. Yeah, unfortunately, yeah.
yeah. While the third one is the one who's got the delay because he was infected in utero.
Correct.
Although
Yeah.
you couldn't find the virus immediately because
Yeah.
it became latent by that time. By the time he was born,
Right.
the skin was not there, but the skin was done. Was injured. Was the brain was also damaged, and he's the one who's going to have maybe longer term problems than the first and the second, because
Yeah.
he's been injured very early in utero, so his developmental delay is going to be prominent.
For the time being, the one who had the 2 episodes really, who is the one who's seemed to be more severe affected compared.
Yeah, it's just
Surprising.
unlucky, isn't it? That's why I was thinking, he said he's not premature or anything,
But
and
he was 29 weaker. He was premature. Yeah.
yeah, and maybe he has got something else as well, as you said.
Right.
It'd be interesting to see what his immunology shows.
Exactly. Yeah. Very interesting one. Very sad.
Yeah.
And then also I have no idea about neonatal HSV infection, and I think the main clue from those pictures I showed you initially really is a hypopigmented lesion in the lower back of that patient. So we looked on the literature. We had a look on for some literature review, and we found a report of 3 cases of intrauterine herpes simplex infection. And they concluded basically more than 2/3 of these patients do not have the typical triad, which mainly consists of cutaneous central nervous system as well as eye involvement. The one with the in utero infection, the baby I presented, the third one, did not have any eye abnormalities apart from some retrombus of prematurity, unless ophthalmologist diagnosed that as I'm not ophthalmologist, so I can't comment on that. But yeah, it was very interesting. In interest of time, I will go for overall management of and guidance for management of asymptomatic neonates born to women with active genital lesions. This is like guidelines from the Committee of Infectious Diseases led by Dr. Kimberland. He's one of the leading figure in herpes simplex infection in this country. So this risk is stratified based on the maternal classification of infection, primary versus first episode primary or first episode non-primary, i.e. if the mother had HSV 1, but did not have yet HSV 2, and then she contracted either virus and vice versa. And this will be based obviously with in terms of the maternal antibodies versus the first episode primary or non-primary infection and the PCR result or culture from the genital and versus recurrent infection. So back to the data presented earlier by Dr. Brown and his colleague, they did some analysis, also sub-analysis before the completion of the studies, which is shown here. So they started with 58,000 women on whom they obtained culture within 48 hours in 69% of these ones. 0.3% of these women had subclinical shedding. Of those, 95% had some serological testing. And based on their clinical presentation as well as the serological testing, they divide them into. Any question, comment, please? Sorry. Yeah. So they divide them into first episode genital HSV infection. That was in 19% of those tested patients. And then divide into primary HSV1. These were 13% versus primary HSV2, and these were 17% of these patients. And then for the HSV1, who were 13 patients, infant with HSV infection were 3 out of that group. For HSV2, only 1 infant had infection, although the proportion was higher, like 17%, such that 57% of exposed neonates develop HSV disease, either 1 or 2. For non-primary HSV infection, there were like 4% of these women. None of them developed HSV disease. For non-primary HSV2 infection, those were 65%. 4 out of these babies develop infection, such that 25% of the exposed neonate developed HSV disease, and was again mainly HSV2 rather than 1. For the recurrent genital HSV, those were the majority of those ladies, 81%. 8% had HSV1, 92% had HSV2. For the HSV1, 2 of the patient had of the newborn born to these ladies had infection. And interestingly, for HSV2, because it's recurrent and probably the mother transferred some antibodies to the baby, none of them had infection. And they come with the conclusion that 2% of those exposed neonates develop HSV disease, mainly due to HSV1, if the HSV infection was due to HSV1 down in the genital tract of the baby around the time of birth. Any comment you say from this?
No further comment. I think this is just confirms what we said earlier, isn't it?
Exactly. Thank you. So based on that, they came with this algorithm, mainly managing asymptomatic neonates after vaginal delivery or cesarean delivery to women with lesion at delivery and history of genital HSV preceding pregnancy. So we start with asymptomatic neonate following vaginal or cesarean section delivery to a mother with visible genital lesion that are characteristic of HSV. So the obstetrician provider should ideally obtain HSV PCR or culture from the lesion, and also do serology. And then the serology is mainly to see if the mother had to classify the mother. If the mother has any history of genital HSV infection, if she has, as a 24-hour, the baby should have a surface culture or PCR ideally, including all of the following, as we mentioned earlier: conjunctiva, mouse, nasopharynx, and rectum, and also had HSV blood PCR sent. If the infant remains asymptomatic, you don't need to start ASAC repair. And then if the testing is negative, you just educate the family about symptoms of HSV neonatal disease and follow closely. If the workup is positive, at that time you do LP for your cell count, chemistries, HSV PCR, and send also serum ALT and start ASAC repair at the agreed dose. If the mother does not have a history of HSV infection, obtain maternal type specific serology for both HSV1 and HSV2 antibodies to classify the mother. Again, at 24 hours of life of the baby, you do HSV surface culture, you do HSV PCR testing, and obtain CSF studies, and you start ASAC repair pending the result of these. And then you hopefully will have your maternal classification, primary versus non-primary versus recurrent, and then that gets the patient into first episode primary or first episode non-primary or recurrent infection. For recurrent infection, either the neonatal viral studies are negative, including PCR, viral culture, and then you stop your ASAC repair and educate the parents again about symptoms of neonatal disease. If the studies are positive, you treat for your duration for 14 days for the skin, eye, and mucous membrane involvement, or 21 days if disseminated or CNS involvement. That for recurrent infection. For the first episode, primary or first episode non-primary, you have to ask yourself, all of these conditions are met, the patient remains asymptomatic, CSF studies are non-suggestive for infection, CSF and blood PCR are both negative, and serum ALT was normal. If that's the case, you treat preventive therapy of infection, but no proven disease, you treat for 10 days with the same dose, only for 10 days. Obviously, if these are not met, i.e. the patient has abnormality in any of these, you treat for a proven infection or disease, and you treat for your 14 days or 21 days, depending on the classification of the disease. A treatment of infection and proven disease, as we say, you go for your 60 milligram per kg per day in 3 divided doses, depending on the duration, depends on the type. And then if you have disseminated, including CNS, you do your repeat CSF, as we mentioned earlier. If it's negative, you discontinue your ASAC repair after 3 weeks of that. If positive, you extend your treatment with another 7 days of ASAC repair, and you repeat your LP. And depending on that, you decide if you want to extend it further. You shouldn't stop your ASAC repair till the CSF HSV RNA PCR is negative totally. So in terms of reporting, this is a manuscript yet to be published, I believe. I found in the Journal of Pediatric Infectious Disease Society. Their 40-word summary, despite its devastating impact, neonatal herpes simplex is not, okay, that's a typo, sorry, is not notifiable disease. As of 2023, this only reportable in 6 states. We do need consistently applied case definition to make diagnosis. And this again, sorry, that's my dictation thing went wrong. So we need to see what modification we can do to optimize surveillance for these babies and any preventive efforts. So that's yet to become. I can share it with you since there's some typos there. So in terms of prevention, obviously, for you have to identify high-risk pregnant individuals, like with multiple sexual partners. You can do cesarean delivery. You can use maternal antiviral therapy, suppressive therapy during the last 4 weeks of the pregnancy, and also give anticipatory guidance for the pregnant individual and her partners. In terms of vaccines, there's no approved vaccine for HSV infection overtly. There's some therapeutic HSV2 vaccine, which can decrease recurrent virus shedding and recurrent genital herpes simplex. And this is based on HSV2 protein, GD2, and ICP4, and matrix M2 adjuvant, which showing some promise in clinical trials so far. I'm not sure if Yusri or any of the parties is involved in that. I have no idea. And I will finish with this slide. It was like a comment on the topic of the mother-to-child transmission. We still need a lot of research in terms the research needs in maternal neonatal herpes simplex infections should include the effect of maternal suppressive therapy on the incidence of neonatal herpes simplex, research and development of optimal treatment strategies for the management of HSV discordant couples to prevent acquisition of HSV infection during pregnancy, vaccine strategies aimed at preventing maternal transmission of HSV, and the feasibility of rapid turnaround prepartum screening of asymptomatic women with HSV PCR being detected, the efficacy of preemptive antiviral therapy in neonates born to women asymptomatic shedding HSV at the time of delivery, as well as research in development of safe novel antiviral agents with increased efficacy, including penetration through the blood-brain barrier for neonates with HSV. As we know, acyclovir is not great in terms of that, but that's the only available medication for so far. Relatively non-toxic. Investigation of the potential benefit of combination of antiviral therapy for neonates with HSV infection. And these are my reference. Sorry, it took me a while to finish that. It was a lengthy presentation. If you have any question, please, you can fire on me. Thank you.
Yeah, it was an excellent presentation. Really, I enjoyed it, and I learned a lot today. I mean, I think last week I was in service, and there was a shortage in acyclovir.
Oh, yeah.
And I think the hospital made a policy. It goes to neonate, and in adult they said, okay, use ganciclovir or use whatever you want to use. The fellow was mad. I told him, I think it is more serious, but I wasn't aware how serious it is in neonate. I think you guys deserve to have it if it is not available. Just question. I have seen a lot of HIV patient. I have seen a lot of sometimes resistant with genital region. Is there any resistant in case, or because it is just like early infection, you guys have not seen resistant to acyclovir?
Honestly, I didn't look on that, but I would imagine mostly there's no resistance in kids. I mean, exposed to this mother with HSV infection, but I can't comment more on that, honestly.
See, I don't know if Yusri is still in the call. I mean, we have seen it in HIV, but I guess because it is recurrent HSV genital lesion, and then they get acyclovir and off and on, and then they develop resistance. But I don't know if that would be transmitted to the neonate or not. And
Yeah,
thanks.
I mean, in theory, Ahmed, in theory, it could happen, but in reality, I haven't seen it at all, despite seeing a lot of HSV or acyclovir resistant HSV in HIV and in hemato-oncology and other transplant patients. But I haven't seen it in this one. And as so you have said, most of the cases are from the primary infections rather than the recurrent ones, the people who have been taking acyclovir prophylaxis or suppressive therapy that led to, or that would normally lead to selection of resistant mutants. So most of these mothers who give the infection to their babies just do not know that they have it, or they have it very late, or their partner had a different serotype, and then they get infected with the other type because they've got multiple partners. And the few cases that I've seen through my life of HSV1 and O2 in neonates happened in women who had new partners during pregnancy. So they that just happens. So the resistance issue is highly unlikely to be relevant in this kind of rare disease.
Luckily.
Yeah, thank you, Ghussai. This is a really great presentation. Actually, I learned a lot. I have no clue about that, all that's presented today. So, just like Ahmed. So, I mean, you see, so just to confirm that most of the resistant cases are actually acquired from the mother. So, kids, they just, for some reason, don't develop resistant while on treatment. Or I'm just trying to understand here. I mean, like it's not like bacteria, right? I mean, the resistant usually strains are actually mostly acquired from mothers. So, do you guys test for like drug activity or susceptibility, or not usually? Because I mean, I see a couple of cases that remain.
Yeah. So like that middle case, Ghusai's middle case, where
Yes.
they had given the patient 3 months or
Yes.
3 weeks of treatment, and then went away, and then in an outside hospital they received another treatment, but still not well. That kind of patient, you may want to do the resistance testing because he's been exposed for some time. But as I said, being a neonate first time presenting with HSV is highly unlikely to be resistant. But in theory, if the mother has got it and is resistant, she should normally, that lady should have antibodies that should have protected that baby from getting it in the first place. So it is unlikely to happen in the first place. But if it happened and she had the resistant strain, it will go. There's nothing stopping it from going. But highly unlikely to be. So if I see a baby today, we'll just give them treatment and we will assume that they are sensitive herpes simplex, unless just they don't respond or something like this. Then people can go. Or if you have got a history that the mother has got recurrent HSV and she's on treatment for a long time, then at that time you should test for it. And the testing, as I said, used to be by culture. You do the monolayers and you test for phenotypically for acyclovir resistance and prove that if Foscan is fine. Nowadays we've got genetics, alhamdulillah. We've got genotypic resistance, just like HIV or CMV. We can straight away find the mutation that are associated with acyclovir resistance. And but of course these are in central labs.
Thank you. In fact, last week I was contacted by the nursery like postnatal ward by one of the pediatric residents saying that the mother had some genital lesion at birth and she was on acyclovir. So they were obviously inquiring about investigating the baby or working out the baby for this exposure. But on further history taken from the mother was not compliant with her medication. And that probably is the reason for the break.
Do you have her booking blood sample?
Was that you say?
Booking blood sample. Do you have a blood sample saved, a serum sample saved from her early in pregnancy? Because you could go back and test that, see if she was seronegative or seropositive. Because if she's seronegative, then you know she was a primary infection, and then the issue of resistance in her will be even more remote.
Yeah, exactly. I'm not sure about that if it's available or not really. The OB are in totally different world here. But the mother was not compliant with her acyclovir. That was she disclosed. Yeah, I think that.
Yesterday?
Yes.
The quick question, since you brought up this antibodies, like, I've had like several incidents where a friend or like somebody would send an IgG for herpes and it comes back positive. What do you tell patients in that case? I mean, they freak out, like they have to tell their partners that they have antibodies, and it's just complicated.
No, she's HSV1 in the first place. So most of the people walking around the street are HSV1 positive, not from genital.
Correct. Yes.
Yeah. So that is easy. There are more difficult situations in sexual health clinic that you will find an explanation for. Otherwise, you are risking many relationships.
Right.
Yeah, because they used to tell us in training, if you order IgG for herpes simplex 2, you deal with it your own. I don't have anything to tell you. You have to do, you deal with it. I don't have any recommendation. Anyhow, this was a very great presentation, Ghussai. Any other question, guys? Any other comments?
This was great. Thank you so much. Yeah. Amazing.
Yes, it was
Thank you,
Ghussai.
Ghussai. Thank you. Yusri, thank you very much, everyone.
Thank you so much, Ghussai, Yusri. Thank you for
Ghussai.
education.
Yeah, I enjoyed so much. Thank you, guys.
Great,
Bye-bye.
great presentation.